and help you guys fix it. So that's my only little complaint today. But what we're going to be covering today, guys, is part 2 of our neuromuscular disorders lecture. So obviously we covered stroke and Parkinson's last week. This week we're going to be looking at multiple sclerosis, MS, and muscular dystrophy, which we're going to call MD today, just to save my breath a little bit. So we'll get straight into it. So here we are. And also just a note, guys, this is our last kind of content-heavy lecture in terms of talking over a chronic disease. So as of next week, I think we've got like a counselling lecture and a behaviour change lecture. And then week 13 is going to be kind of a course review. And I'll be talking over the exam format and what you guys need to be focusing your study time on. So obviously we have still got 2 more lectures that are going to be covering content, but I feel like it's going to be hopefully a little bit more refreshing, and we're not going to have to, discuss the pathophysiology of any kind of new condition. So I do understand it might become a little bit of a slog in these last couple of lectures, kind of talking about new conditions and all this kind of stuff, but just stick with it the best you can. Again, same thing applies this week as it did last week. We're not going to expect you guys to be experts on these 2 conditions by the end of today, but we're just kind of skimming the surface, hopefully spreading some information and awareness of these 2, and obviously giving you guys some advice of how you might be able to help individuals suffering with these conditions in an exercise environment more than anything. So as always, guys, key references. So you've got your ACSM references here. Say no more. And then we've got some extra resources. So your organisations in Australia, we've got the nationwide one and the Western Australia specific organisation for your muscular dystrophy and your multiple sclerosis organisation. So heaps of resources on there. I say it every week. I hope you do go check them out and have a look. I'm not going to be presenting any videos today. The reason being, there's a heap out there, and a lot of the better ones are actually quite longer. So what I'd recommend instead is you get onto some of these websites and just have a look at the sort of the living with, the condition, patient stories, if you like, just to get a bit of a vibe for, I'm going to talk to it, but how it actually does impact people's lives, because I think that can sometimes be the most valuable and I guess real way of getting a feel for these conditions. So, as I said, guys, part 2, multiple sclerosis, multiple sclerosis, muscular dystrophy, better not get those mixed up. And as we said last week, a neuromuscular disorder is a condition that's related to either the neural or the muscular tissue of the body, just to reinforce that definition. So kicking off with multiple sclerosis to begin with, and I'm going to refer to this as MS throughout the lecture, just to save my breath, as I said. So specifically on Australia, now the prevalence is a lot lower than some of the other conditions we spoke to this semester. So we're looking at about, over 25,000 people are affected by MS in Australia. So it is a large proportion of people, but obviously in terms of the overall population, it's a much lower percentage than some of our other conditions we spoke to. Nevertheless, when we get into the symptoms and the impact it has on daily life, that's extremely significant. So whether it's a large proportion or a large proportion or a small proportion of society, the same applies in terms of wanting to try and help these individuals live a better quality of life and obviously reduce the burden on themselves and the healthcare system and obviously their nearest and dearest, their family members and children and parents and whatever it might be. So it doesn't take away from the importance of trying to help and understand these conditions in terms of exercise treatment, just because it's affecting fewer people. So MS is mostly diagnosed between the age of 20 to 40 years, and it affects a lot more women than it does men, so about 3 times as many women. Around 50% of MS sufferers do have severe limitations on their ADLs, their activities of daily living, due to the condition. And around 63% also suffer some kind of, or experience some kind of restriction on their employment, which is pretty huge when you think about it. So obviously it's going to impact their potential, their financial situation, etc., etc. Now, the annual economic burden of MS in Australia is currently estimated at $1 billion, which you kind of lose a bit of perspective. We've spoken about multi-billion dollars previous weeks. $1 billion is still a lot of money. So yes, it's lower than some of the more prevalent conditions, but there's still obviously a huge economic burden there. So when we're trying to define MS, what we're talking about. So MS, it's a chronic inflammatory autoimmune disease of the CNS, which is our central nervous system. so brain, spinal cord. Now, the term sclerosis kind of describes abnormal hardening of body tissue. And ultimately what's happening, which we can see in the figure on the right, is this injury to the sheath that covers the nerve fibres, which we call myelin. So the myelin sheath is basically being damaged, which protects the nerve fibres. Okay, and we can see obviously neuronal myelin sheath on the left, and we can see the damaged myelin sheath on the right. So this is ultimately going to have a knock-on effect to the function of that nerve. So a little bit more pathophysiology, we get what we call nerve demyelination occurring, and that's due to an attack from activated T cells that cross the blood-brain barrier, so hence the autoimmune factor. So as we said, the myelin sheath that protects the nerve fibre is slowly being destroyed, and the nerve signals therefore have difficulty doing their job. The nerve cells therefore have difficulty doing the job and sending the relevant signals around the body for whatever function they're responsible for. So following the initial inflammatory response, we get damaged myelin and we get scar-like plaques forming. Okay, so these are what we call areas of sclerosis. Now that scarring is going to impair the nerve conduction and transmission, and again that's going to cause our nerves to function suboptimally. So MS can affect different areas of the CNS, which is something to bear in mind. And regarding the exact cause, it's still unknown, okay, but the theory and the kind of belief is, and what kind of our current understanding is thinking that there might be a virus in early years in life, okay, that kind of lays dormant, and then in later years, multiple sclerosis, the disease is actually triggered by an abnormal immune-mediated response that might be influenced by a combination of environmental, infectious, and genetic factors. So potentially there's a virus in the younger years, lies dormant. Later years we'll get this abnormal immune-mediated response, and it could be a combination of environmental, infectious, and genetic factors, which obviously creates quite a complex picture, because it could be a multitude, it could be a different combination for different people. But ultimately, when it comes down to it, the bottom line being the immune system is attacking the myelin sheath of the nerve cells, and that's what you really need to remember. So what are some risk factors for MS? So I won't put too much emphasis on this, because I mean there's not a definite small age bracket where your risk is particularly heightened, but what we know is that MS can occur at any age, but it usually affects people between 16 to sort of 55 years. As we said, a diagnosis is more so common between your 20 to 40 year age bracket. So, not so much youth, not so much elderly, sort of post 65 years plus, which we see with a lot of our other conditions. But as you'll see with a lot of these risk factors, guys, they're not, we'll talk to them, but they're less modifiable, the less lifestyle modification compared to a lot of other conditions that we talk to, okay? And this can often be the case with our neuromuscular conditions. So as we said, women are 3 times more likely to be diagnosed. So obviously sex is a factor. Family history, if you have a parent or a sibling with MS, you're going to be at a heightened risk. Particularly infections, so there's a variety of viruses that have been linked to MS, and Epstein-Barr is one of those. Ethnicity, so Caucasian ethnicity, which is specifically Northern European descent, is known to have a higher risk. Don't ask me why. Stats are showing us that's the case. If you have low vitamin D levels or sunlight exposure, that is also known to be a risk factor. Also certain autoimmune diseases, so including thyroid disease and type 1 diabetes. And smokers are also known to be more likely to develop MS. Again, not really sure of the mechanism there, but we've seen smoking as a consistent modifiable lifestyle risk factor throughout semester for pretty much all of our conditions. So as you can see, there's a few things there that we have a little bit of control over, but there's also a lot that we can't control. So what are our common symptoms in MS? So one of the main ones, and particularly key in the first early signs of MS, is visual disturbances, so particularly eye pain. I'm going to talk about this in a bit more detail. So muscular weakness and stiffness, fatigue, dizziness and vertigo, walking, balance and coordination problems. So you're starting to get a feel now for all these complications and special considerations that we're going to need to pay attention to as an exercise professional, okay, someone that's trying to promote exercise in these individuals. Bowel and bladder problems, one of my best friend's parents has got MS. Unfortunately, it's pretty stable, but and she's got a fantastic sense of humour, which helps. But yeah, she's constantly has to deal with going to the bathroom. She might be at work. She's got no control over it. So reading these things off a slide is one thing, but seeing, you know, someone having to deal with this stuff in real life as an adult is a totally different thing. Sexual dysfunction, slurred speech, difficulty swallowing. We spoke about a few of these that were also relevant to last week's Parkinson's disease. So cognitive dysfunction, including forgetfulness, memory loss, confusion, difficulty concentrating or even problem solving, depression, which we can see is going to be pretty apparent based on a lot of this stuff here. Paresthesia, which refers to tingling, numbness in the hands, the feet and your limbs, so your upper and lower limbs are the most common areas, and also potential for muscle spasms, so spasticity, which we spoke about, so that real kind of over contractile activity in the muscles. So it's not to say every patient you're going to see is going to have all of these symptoms present. It might only be a couple. It depends on sign of the severity of the disease, where they're at in terms of the disease progression and the timeline, if you like. But it's good to be aware of the various symptoms. And of course, if you ever are going to work or try and exercise somebody with MS, you're going to have to know in a lot of detail which one specifically they're dealing with on a day-to-day basis and what's more likely to be present in an exercise context. So we've just got a visual here. I won't go over these, but it's just a bit of a visual summary of some of those key symptoms that we've just spoken to. So yeah, it might just help you soak that in a little bit more. So optic neuritis, which I spoke to, is defines or describes this painful blur and a loss of vision. And like I said, guys, it's one of the most common symptoms in our MS patients. And it is, in 15 to 20% of diagnosis, it is the first sign of MS developing. Okay, so the lifetime risk of developing MS after an episode of optic neuritis, is around 50%. So if you see this happening, you know, it's a toss of the coin as to whether you are going to develop MS or not. It's a pretty indicative sign in a lot of cases. So what's going on is we've got acute inflammation or demyelination of the optic nerve, which sits at the back of the eye, which you can see in the diagram there. So when this becomes inflamed or there's that damage to the myelin sheath, you can get this vision loss or this blurred vision. Now, when it's an acute instant or an acute, what's the right word, bout, whatever, presentation, people usually recover within 6 weeks, but what we'll talk about later is this can relapse and kind of occur and then get better and then occur again, etc., etc. Now, another thing to be aware of is in MS individuals, there is heat and temperature sensitivity. So another really important consideration. So many people with MS experience a temporary worsening of symptoms when they're exposed to hot and humid conditions. So this includes, obviously, hot weather is an obvious one, but also hot baths, showers, if they're experiencing any kind of fever or infection, and also overexertion or exercise in a warm climate. So we know body temperature is going to rise in exercise regardless, but when you're doing that in a hot environment or a warm environment even, that's something you definitely need to avoid with your MS individuals. So what we know is when the temperature increases, we're going to further impair the ability of those demyelinated nerves to conduct the relevant electrical impulses. Therefore, we're going to see a further deterioration in whatever symptoms it might be. Specifically, blurred vision being exacerbated by heat and temperature is what we refer to as UTOF sign. Don't worry about that too much. UTOF was the surname of some German scientist back in the day who discovered this kind of phenomenon, I guess, within MS, this heat sensitivity. But yeah, very much important to be aware of this. Oops, sorry, shooting through slides here. So in terms of diagnosis, an interesting one is previously, following on from what I just spoke about previously, they used to put suspected MS individuals into a hot bath and used to monitor whether their symptoms worsened or not. And that used to be pretty, used to basically confirm whether somebody had MS or not. Now, obviously, we've come a long way and we've advanced a lot in terms of technology and medicine since then. So what happens in the modern day is we get a complete neurological exam and obviously medical history. But within MS diagnosis, we're more often than not, we're trying to rule out other conditions with similar signs and symptoms. That helps kind of narrow down this potential for MS. So there's a pretty broad range of conditions that might be present based on the similar signs and symptoms. So we try and kind of, eliminate them based on other investigations. But what we can use to help confirm MS is an MRI, so a brain scan, or an MRI of the spinal cord. We can look for lesions, we can look for, we'll show you one in a second, but we can actually start to see where there might be MS present, or there might be the damage of MS, I guess, remaining. Blood tests, so currently under development, we've got specific biomarkers that are associated with MS, so these tests kind of, being researched and validated as to whether they can help with a diagnosis. And then finally, spinal tap or lumbar puncture procedures is basically where we take a small sample of fluid directly from the spinal canal, and that can help show, we can detect if there's any abnormal antibodies present within that fluid that could be associated with MS. So obviously we can see there's a few different potential investigations there, but fortunately we've come a little bit further than just putting people in a hot bath, which is a good thing. So here you've got an example of your MRI brain scan. So we've got a healthy brain here, and we can just start to see these lesions or plaques, as they might refer to, which are being caused by MS. So you can see those kind of white areas, and they've spread throughout a few areas of the brain there. So that's just one example of how we might see this detected using MRI technology. So there's 4 types of MS that we're going to talk to. Now the first one, the main one, is what we call relapsing remitting MS. Now this covers 85% of total cases, so it's the most common type of MS that you're going to come across. And what's happening is, the clue is in the name. Symptoms suddenly reappear every few weeks. They can last for a few weeks, months, and then we go back into remission. So it's got this constant, relapsing remitting kind of pattern. Secondly, we've got primary progressive MS. So this is about 10% of cases. We've got symptoms that are gradually worsening after the symptoms first appear. We don't have any plateaus, any kind of, improvements in conditions. So it's pretty much just this primary progressive kind of line, this pattern. Secondary progressive MS. Okay, so this relates to the first type. So after years of presenting with relapsing remitting, symptoms then begin to progressively get worse. And they just continue to get worse. So we don't get this kind of, relapse remitting kind of pattern anymore. It goes from that pattern to just a continuous progression after that point. This will occur in 50% of your relapsing remitting MS cases within 10 years of diagnosis, and for 90% are going to transition to secondary progressive MS within 25 years of their initial original diagnosis. Last one, just to quickly point out, is about 5% of cases, and this is what we call progressive relapse in MS. So symptoms gradually worsen after their first appearance, and there's distinct relapses, which are kind of superimposed on this steady progression. And you might be able to see it clearer here. So if we just look in the blue, we've got the top type, the most common, relapsing remitting, and you can clearly see that pattern over time. We know that 90% of those cases are going to progress into secondary progressive, which is in kind of your orange brownie line. So you can see that relapsing remitting pattern and then just that steady progression. Primary progressive is just continued progression from the first appearance of the symptoms. And then we've got progressive relapsing, which kind of has a combination of the two presentations. So just to make you aware of the scale, so abbreviated as EDSS, so the Expanded Disability Status Scale, all right? And I think this was developed by a researcher under the name of Kurtzke. So just to make you aware of the scale, it is specific to MS, so we've got a rating of 0 to 10. Now, we want to avoid 10 because that's death attributable to MS, okay? So we want to be as far down the disability scale as possible and as close to 0 as possible. So 0 to 2.5 is going to represent none to minimal disability in an MS individual. And then obviously with disease progression, we're probably going to see this increase in disability. So this is a tool that can be used in a medical environment as to sort of categorize and look at the disease progression. So impact on physical function. So obviously starting to get into the information that we're more sort of concerned with now. 2 key considerations and things that are presented by your MS individuals: they have a much lower exercise tolerance and they have a higher perceived fatigue. Okay, so they can't withstand as much exercise, and they also get fatigued a lot quicker than a healthy, normal individual. I shouldn't say normal, everyone's normal, but a healthy, age-matched individual. Now, these impairments, so the exercise intolerance and the higher fatigue, there might be a result of the disease, but they're also no doubt going to be a consequence of reduced physical activity in individuals with MS. So we talked about this many times over the semester, vicious cycle of deconditioning. As we have a disease condition, we're going to have more barriers to being physically active, so we're going to become more physically inactive, deconditioning of the muscles and the cardiovascular system. We're going to be even less inclined to do exercise, and then, activities of daily living, basic tasks are going to become more difficult and have a higher energy cost. We can also see motor fatigue, and we're going to see, muscular weakness in the lower extremities. That's eventually going to progress into the upper extremities as well. So we've got our ACSM guidelines here now. There's probably nothing too significant to point out. I think it's important to present these, but as I've said a few times, this is your skeleton, your absolute baseline, starting point of prescribing exercise for people with MS. So when you're working off these, you're in the right safe ballpark, you're following the evidence-based guidelines, but obviously this provides you very little kind of detail in the sense of the specific acute training variables. And what we mean by that is, exercise selection, exercise order, time of day, how you actually fit it into somebody's lifestyle, and more importantly, making sure they enjoy it and making sure they're going to adhere and comply over the long term, because that's number one. There's no point giving somebody something that they're not going to do. All right, so the perfect program is usually the program that they're going to do. So there's a few papers here just to quickly present support both aerobic and then resistance training in MS individuals. So this was a short-term exercise training program, and they looked at the impact on aerobic fitness, fatigue, and health perception activity level of MS individuals. So it was only over 4 weeks, which is obviously quite a short training period, but I think they exercised 5 times per week. So they did 5 30-minute sessions on a bike ergometer per week. There's 26 MS patients. They looked at matching them to, they compared them to 26 people without MS as a control group. So what they found were maximal aerobic capacity and lung function paired with baseline. The MS training group demonstrated a significant rightward placement of the aerobic threshold, AT, an improvement of health perception, an increase in activity level, and a tendency to less fatigue. So obviously potentially some promising findings there, and that's after 4 weeks. Okay, so imagine what would happen potentially after 8, 12, so on and so on. Another study here, so we've got the effect of aerobic training on walking capacity and maximal exercise tolerance in patients with multiple sclerosis, and this was a randomised crossover control study. So again, just talking about the background and purpose, physical deconditioning we know is related to impaired exercise tolerance in MS patients. So we had 19 subjects, 11 subjects completed the study, so there was a little bit of dropout for whatever reason. In terms of results, so this was actually looking at aerobic training and then comparing it to standard neurological, is that right? Neurological rehabilitation, yeah, which is your NR. So after aerobic training, but not neurological rehabilitation, the subjects' walking distances and speeds during a self-paced walk were significantly improved, as were the maximum work rate, the peak oxygen uptake, and the oxygen pulse during cardiopulmonary exercise tests. So some pretty strong markers there and parameters in terms of cardiovascular health and performance. So yeah, just a conclusion, the results suggest that AT is more effective, so aerobic training is more effective than neurological rehab in improving maximum exercise tolerance, which I think you would expect, because I'm not entirely sure what the neurological rehab was composed of, but doubt there was an exercise stimulus in there, and walking capacity in people with mild to moderate disability secondary to MS. So again, some nice positive findings there, just supporting the use of aerobic training and what it can do for people's physical function with MS. So moving on to resistance training. So the first study I'll present here is resistance training improves the strength and functional capacity in persons with MS. So 8 MS subjects volunteered. They completed twice weekly training sessions. So I believe this was various exercises, 8 to 10 reps at 50% of MVC, which is the maximal voluntary contraction. So knee flexion, knee extension, plantar flexion exercises. So all based in the lower extremity. And as you can see, when you get down into the results, so knee extension, plantar flexion, stepping performance were increased significantly post-intervention. Self-reported fatigue decreased, and disability tended to decrease following the training program. So some, again, pretty cool findings there. Twice weekly training sessions, not a huge burden. We can really make some big differences, which are obviously going to have a huge impact on these individuals' lives. Last one here, so this is specific more to gait kinematic. 8-week lower body resistance training program. Various gait parameters were looked at in terms of knee range of motion, duration of stance, swing, double support phases in seconds, stride time, step length, foot angle, all your specific measures in terms of walking gait and getting a real in-depth analysis. And what was found was after 2 months of resistance training, there were significant increases in various parameters that were measured. And ultimately, we also saw improvements in isometric leg strength in 2 of the 4 muscle groups tested. Fatigue indices decreased, and self-reported disability tended to decrease as well. So resistance training may be an effective intervention strategies for improving walking and functional ability in moderately disabled persons with MS, which again might sound pretty, simple, basic, but we know there's going to potentially be gait issues, there's going to be progressive, muscular atrophy and weakness in these individuals. So being able to maintain good walking gait over the course of the disease is actually a really important and positive result. But moving on to special considerations, we've spoken to this a few times, and it's apparent in other disease conditions as well, but we have to be really adaptable with our approach to exercise. So we need to consider that regular progression and regression of the program. So we're kind of working on a continuum in line with the likely relapse and remitting kind of pattern that we're going to see in a lot of our patients. So your training program, it should be a flexible document. You need to be ready for the days people aren't going to be able to do what they would be able to do when they're healthy and not in a relapse. So just something to be aware of, and obviously make sure you've got good, clear communication with your client or the individual when they are going through times when symptoms are heightened. Consider the fact that you might need to use an assistant, a support where necessary. So if movement is deteriorating, then thinking about, if the patient is bringing a family member, a friend, a carer, you might just need to lean on them in terms of getting them into certain positions. Now, this is obviously more so with your more severe cases. I know a lot of people with MS that come into gyms and they're pretty good when it comes to movement, getting in and out of machines, potentially using some free weights and various modalities of equipment. But it's just something to be aware of with some of the more severe cases. Obviously, the use of walls, doorways, backs of chairs are going to be really smart for being able to just provide that stability and that support where needed as well. Where there is an exacerbation or a relapse, you really just want to be focusing on maintaining ADLs, and that's a win, okay? So if they're regressing and they're relapsing, just being able to help them maintain the ability to be independent and be able to do the ADLs is super important, okay? So just be patient with that, and obviously when they do once more recover in the better position, you can then work more so on that progression of the program. So you, again, are part of this ongoing medical surveillance, so you need to closely monitor signs of worsening of symptoms. If there's any fatigue, if there's any, paresis is more heightened on a particular day, you need to take note of that. You need to communicate that appropriately. And also be wary, with that fatigue, you're potentially going to have much longer rest times than you would with other people, okay? So being patient with that rest interval, making sure it's appropriate for whoever it may be, and you're really understanding the fatigue presentation in the individual that you're dealing with. A few more special considerations. So fatigue's typically going to be lower in the morning, so take advantage of those periods. You're probably going to want to get your main training in then, whatever it might be. Think about the climate, so you want to make sure that you are not in a warm or a hot or a humid environment, because we know that's going to cause some problems. There might be some autonomic dysfunction present, so don't be relying on heart rate for aerobic intensity measures. Think about using RPE scales, keep it simple. Intermittent exercise can be really useful when you're trying to prevent or delay fatigue, so accumulate shorter bouts rather than just going for one big hit. And a few final ones just to be wary of. So medication side effects. We know In most of our conditions is potentially going to be pharmacological intervention. Specifically in MS, a lot of these meds can give flu-like symptoms. If they're being injected, they could get some localised irritation at that site. Also be aware, because there are bladder control issues and a lot of individuals dealing with MS, people might actually be restricting their fluid intake. So when they start exercising, you really need to be wary of dehydration. So keep that in mind. Cognitive deficit might obviously impact their level of understanding and memory. So if you're trying to coach some exercises, you're going to have to, again, be creative with the different types of cues you give, how you explain movements, etc. And also not just expecting people to know exactly what they did last week and being able to replicate it again. So cooling strategies is also something that's being investigated in MS individuals when they're exercising. So thinking about using things like cooling packs, making sure there's fans. And if there are worsening symptoms, you really need to adjust the exercise time and intensity. So you need to modify the session. Don't just keep, churning out a session because it's planned on paper when you can visibly see someone is struggling and, symptoms are deteriorating. That means you have to act and you have to consider that. So we know we've got a significant reduction in heat tolerance in around 60 to 80% of our MS cases. This can be due to passive heat exposure, exercise metabolism, or potentially both. So we need to be aware of that. Where we can control that, we need to control it. 0.5 degrees Celsius is actually considered a critical change, and we know with that kind of change we can see a significant increase in fatigue and symptomology, which are whatever symptoms that is specific for that individual. But the vision loss is usually the most commonly worsened. So if somebody's, exercising, starting to get hotter, warmer, complaining that vision problems are worsening, then you need to take note of that. Don't just, skim over it. So this was just a study in 2010 that looked at the use of pre-cooling in individuals with MS, and you can see, so the dark dots at the bottom of the figure, so we've got core temperature up the y-axis, we've got time along the bottom x. So during the exercise component, which was 40 minutes, then we've got recovery that followed. So in those 40 minutes, we can obviously see an increase in core temperature, body temperature, as we would expect with exercise. But we can see that those individuals that were pre-cooled are starting at a much lower core temp, and then obviously we're getting less of an increase. So we're not reaching that critical threshold of just above 37.5 degrees Celsius, which these authors defined, okay? And above that, I would imagine, is where you're going to expect to see deterioration of symptoms and worsening of symptoms, which are obviously going to inhibit and prevent and limit what you can do in terms of exercise. So what we're going to talk about next is muscular dystrophy. Now, I'm certainly not an expert in this. I have obviously some understanding, and I've never worked with a patient with muscular dystrophy. It's kind of one of those conditions that I find a little bit harder because it affects young people. It drastically cuts their life expectancy. It puts young people in wheelchairs, and again, people don't do anything wrong to get this. It's not, we can't control getting it. It's not like these people are, have got a heap of modifiable factors that they should have been doing or whatever it may be. But it's not a huge prevalent condition. But like I said to the MS content as well, it doesn't mean to say that we shouldn't be interested and we shouldn't be learning with how we can potentially help individuals with MD. And exercise therapy, again, does have its place in terms of trying to help these people achieve the optimal quality of life while they're here, basically, and while they're trying to get through it and manage it as best they can. So in terms of background, now again, I'm assuming people probably aren't as clued up on muscular dystrophy. People might have been a little bit more familiar with MS, but we're skimming the surface today, guys, but we'll try and get a decent sort of base understanding. So we're talking about a disease of the skeletal system. Now, diseases of the skeletal system in general are referred to as myopathies, and they are surprisingly common, and many of which are acquired due to other chronic conditions. So, for instance, I'm not sure what the mechanism is, but people with chronic kidney disease can be predisposed and at a higher risk of skeletal system disease. Now, myopathy, in terms of a literal translation, so in sort of Greek terms, myo is muscle, pathy is suffering, so it's basically muscle disease. Okay, so suffering of the muscular system. So some myopathies are congenital, and this includes your muscular dystrophies or your MD. So I'm going to use that abbreviation. So the general term MD describes a very diverse group of several different myopathies. Okay, now mostly these are affecting the skeletal muscle, but some can also affect the heart and the cardiac tissue, which we'll talk to. So most MDs do become apparent in youth. Some can manifest sort of later in adulthood, but still they're pretty much all going to be present by that middle age kind of age range. So within Australia, similar stats, so similar kind of figures to MS. We've got around 20,000 Australians living with some form of MD. The term describes over 30 genetic diseases, but the two that we're going to focus on today, obviously we can't cover all of those in a lecture, and they're all very complex in their own right, but the two we're going to stick to today are Becker muscular dystrophy, or BMD, and this is affecting around 1 in sort of 17,000 live male births, and we'll talk about why it's more prevalent in males. And then Duchenne muscular dystrophy, which is DMD. Slightly more severe, aggressive progression in terms of disease and its time course. But this is sort of currently present in 1 in 3,600 live male births. So the economic burden of MD is around $1.5 billion per year in Australia, and that comes out at around $126,000 per individual. So when I was doing a bit of preparation for this lecture, I actually read some interesting articles around the economic burden, and some of it was talking to the fact that historically MD hasn't really had a heap of awareness, and there hasn't been a lot of kind of financial support there for the patients and their families, which is pretty scary, because if somebody was to have a child that developed MD and they were facing, financial costs of up to $126,000 a year, then it's going to be a pretty bleak scenario, and there's going to be some real stresses and pressures and issues with trying to achieve that optimal care. So within that economic burden, we know it could be direct healthcare costs, it could be aids and equipment, so thinking about wheelchairs and all the supports and everything that you need to adapt the household in order for somebody to live with MD. Personal care, potentially even transport, and productivity lost, which obviously the productivity lost is going to be direct for those individuals that sort of have this further into their adulthood. In your more child cases, going into adolescence, early 20s, it might be due to the fact that their parents or carers or whatever it might be are unable to work because they're caring for them full time. So in terms of pathophysiology, both your Becker and Duchenne MD, what's happening is they both lead into this progressive loss of muscle strength and functional ability during childhood and adolescence. Okay, now the conditions are caused by an X-linked recessive genetic disorder, and what this leads to is a complete deficiency or reduced expression of dystrophin protein. Now, what dystrophin does is it provides a vital support for the muscle cell membrane, which we refer to as sarcolemma. So just to clarify, Becker's MD is slightly kind of the less severe of the two that we're going to talk about today. So that causes a reduced expression of dystrophin, but not a complete deficiency, whereas Duchenne's muscular dystrophy is a complete deficiency. So that's obviously going to have a more aggressive and progressive course of disease, I guess. Okay, and you can just see on the right-hand side, you should all, no doubt you've all done muscle physiology at some point, but right down to that muscle fibre level in terms of the cell membrane wall, describing all the individual muscle fibres, that's basically what is being impacted by this disease, and that's due to the, like we said, the dystrophin protein being significantly reduced or absent. So where we've got less or no dystrophin, we're going to have progressive muscle degeneration. So what's going to happen is the muscles are going to become a lot weaker. That's going to occur more so in the proximal muscles to begin with, so the ones closer to the centre of the body, and then it's going to span out to our more distal muscles and into the upper and the lower limbs and extremities. So In DMD, so in Duchenne's, unfortunately, very upsettingly, sufferers actually lose their ability to ambulate independently pretty much before or by the age of 13 years. And for some people, that's going to be 9, 10 years. It can vary slightly, but at a very young age, individuals are going to be wheelchair bound. As we said, BMD, so Becker's, is a milder variant of Duchenne's, because some of that functional dystrophin remains, okay? So, like we said, reduced dystrophin versus complete deficiency. And therefore, Becker's MD generally shows better functional prognosis, and it might not actually be diagnosed until later into adolescence, where that disease has kind of run its course enough to start showing some symptoms. Now, just to add another sort of layer to this, dystrophin is also expressed in cardiac muscle tissue. Okay, so cardiomyopathy is also extremely common and is present in around 90% of cases of both Becker's and Duchenne's MD. So when we talk about cardiomyopathy, there's a few different types, okay, but one that I believe and understand to be most common in MD is dilation cardiomyopathy. So what's happening is the heart is becoming inflamed, it's becoming enlarged, the cardiac tissue is starting to stretch, and therefore we get weaker tissue. Pumping ability of the heart to pump blood around the body is basically a lot more inefficient and ineffective than it should be. Now, cardiomyopathy is actually the cause of death in around 50% of cases of Becker's muscular dystrophy. So it's kind of this balanced rate of mortality being due to the cardiac issues or the skeletal muscle issues, where in Duchenne's, because the skeletal muscle is sort of impacted at a much quicker rate, that typically is the issue that's going to lead to the most deterioration of that individual versus the actual cardiac complications that come with that. So it's around 20% of cases in DMD. In both cases, as we said, guys, obviously very sad story. We've got a much shortened lifespan in anybody dealing with these conditions. So DMD, the average lifespan is around 26 years. People can live up to 40 years if things go their way and the disease is potentially not, doesn't accelerate as quickly. However, it's in few individuals that's going to occur, and in your BMD individuals, it's around that middle age where people are typically going to make it to. So either way, it's not a nice thing in either condition. So when we talk about this X-linked genetic disorder, what we're referring to is the X chromosome. So when two individuals have a child, so basically what happens is someone has to be carrying the defected X chromosome, which causes this dystrophin issue. Pretty much always going to be the mother. The only way it could be the father is if the father does have MD, because he's only got one X chromosome. So mother, father, if two X's come together, you're going to be having a daughter. If an X and a Y comes together, you're going to be having a son. Now, X and X is going to create a female, it's going to create a girl. They have, even if they get the defected X chromosome from their mom, they're still going to have an alternate X chromosome from their dad. So they're not necessarily going to be impacted by the condition, but they would be a carrier. But what can happen is if that defected X chromosome from the carrier mother matches up with a Y chromosome from the father, they don't have an alternate X chromosome to rely on. So they have to deal with a faulty one, which is affected, and that means that they're going to present with muscular dystrophy, okay? So again, just another kind of way of looking at it here. It's going to be a lot more common in males, as we say, because wherever there's a carrier mother, there's going to be a 25% chance of having a affected son. So 50-50 whether they're going to have a male or a girl or a boy. But if they do have a boy, there's a 50-50 chance again that is going to be impacted by that defective X chromosome, which is going to cause the issue, and they're stuck with it. They haven't got another, okay? Whereas at least the female has a functional one, so they're not going to suffer, I guess, the same severity of the condition, if the condition at all. So there's just a bit of a visual here on your progressive muscle wasting, which is obviously going to lead to the weakness, the loss of motor function, and ultimately early death. So if you look at the timeline, we've got a DMD patient between 0 to 30 years. Initially, we start to see some walking problems within the first couple of years of life, and this can go to sort of post 10 years. Then we're going to see the individual be wheelchair bound, and progressive skeletal deformity is going to occur. Start to sort of lose the use of their extremities, so not being able to use your arms anymore. Then we can start to have to rely on CPAP machines for ventilation because the use of our respiratory muscles are no longer working effectively, so we've actually got to rely on mechanical ventilation. That can go from just being during the night to being 24 hours a day, and then obviously things worsen until unfortunately people do pass away. So in terms of symptoms, each form of MD does present different symptoms. The type of the age that symptoms present, are going to depend on the type of MD, which we spoke to. So infancy, childhood versus young adulthood. Obviously, we just spoke to the kind of symptom presentation and timeline of DMD. We know it's going to be a little bit later in Becker's MD. Symptoms can be mild, they can progress slowly, or they can progress very rapidly. So even within those two disease types, you're going to get a little bit of variation. It's not necessarily a one-size-kind-of-fits-all for every patient with the condition. So what are some common symptoms? So we've got muscle pain and weakness, which is an obvious one. Considering the pathophysiology, we know weakness is going to occur. And obviously we're going to have that progressive muscle wasting, so we're going to lose function. Difficulty walking, as long as people can still walk, they're going to have quite a pronounced obscure gait. So this is referred to as a waddling gait, which you can look at videos of this, there's heaps of them, but just as it describes, there's a lot of excessive kind of waddling within that gait, and that's just due to lacking a lot of that that musculature that kind of controls and stabilizes the pelvis and everything else that's involved in gait movement. Frequent falls, calf pain. So just to note as well with calves, you get a lot of people look like they've got actually quite hypertrophied calves, and don't confuse that with muscle because it's quite often actually a lot of fat tissue and then a lot of scarring and fibrosis. So don't mistake it to be muscular and have really hypertrophied muscles. We know that's obviously the absolute opposite of what's happening in this disease. Obesity, so obviously due to the deconditioning and limitations with being physically active, we can see excessive body fat. Joint contractures, so this basically means limited range of motion, whether that's passive or active, but this can again be due to changes in a lot of those structures and obviously restrictions and stiffness in various different tissues, ligaments, tendons, muscles, etc. Drooping eyes, so even down to the level of like the muscles controlling the eyelids can start to be impacted, and you can start to see, it's not necessarily in both eyes, but you could see one of the eyes starting to droop. Mental impairment as well, which is a lot more common in the more severe type of Duchenne's versus Becker's, but it can also start to impact the individuals mentally as well. So here's just a bit of a visual summary of a lot of those sort of signs and symptoms that we just spoke to, and you can see here quite it's a good visual for just kind of seeing that pronounced and obscure kind of gait pattern, and obviously that's just due to the impact of all these weak and weak and out of position muscles to what you'd see in a normal healthy gait. So hip extensors, so if you're looking at your glutes and your hammies, they're obviously not going to be able to maintain that hip extension. You've got weak core and abdominal muscles, which means you're going to have a lot of anterior pelvic tilt. You can read through them all yourself. If you're looking at the ankles, we've got potentially tight ankles and restricted range of motion there, and then couple that with weak muscles in the front of the leg, which are your dorsiflexors. You can actually be walking up on your toes. So like I say, I'd really recommend you just hit up a few videos just to see this kind of movement. There's heaps out there, but yeah, very pronounced and very noticeable. So just a few more points here on Duchenne specifically. So as we said, I don't think there's anything here we haven't covered, but it's a more severe type of MD. most commonly affecting young boys, so it's 1 in sort of 3,600 births, and the more pronounced onset is between sort of 3 to 4 years commonly. Common signs and symptoms, so there's a few there that we've just spoken about from the previous. One to note as well is difficulty in rising from a seated or a lying position. So obviously when you're losing all that strength and muscle in your lower body, you're going to start to rely a little bit more on your upper body. So you start to see children at a young age really having to start to sort of use their arms when they're trying to get up off the floor, which is again quite a common sign for these young children. So Becker's, as we said, a little bit later, so it's affecting older boys, younger men, less aggressive, so it can progress very slowly. We might see an onset of symptoms post 12 years of age. Symptoms are similar to those of Duchenne's. From what I understand, there's much of a less kind of cognitive and mental impairment. But we can see severe respiratory and cardiac problems being common by early adulthood. Okay, so still extremely high disability and impact on the individual. So trying to think about diagnosing MD, obviously there's going to be the physical exam, medical history, no questions asked, bog standard, but there's also some specific investigations, as you can imagine. So muscle biopsy of one of those. So if you look at the needle on the right, anyone that isn't familiar with what a muscle biopsy is, again, you can look on YouTube. Not always the nicest thing to watch, so just be careful if you're not good with needles and things like that. But basically just extracting a small sample of muscle tissue directly from the muscles. So often than not, this can be the quadricep or one of the larger muscle groups. DNA genetic testing, electromyography or nerve conduction tests. So this is where we actually use electrodes to try and test the electrical impulses, so the signals of the muscles, to see what kind of function there is, and potentially also blood enzyme tests. So these might help reveal muscle damage, and CK or creatine kinase is one of your more common biomarkers that could be used in that setting. So in terms of treatment, unfortunately, as you probably guessed, there's no cure for any form of MD. Medications and therapy certainly can slow the course of the disease, and just as importantly, they're going to help support that individual to achieve the best quality of life. In terms of meds, glucocorticoid therapy has been used, which tries to slow down the decline in the muscle strength and the functional capacity. And current research is actually looking at gene replacement therapy. So trials using viruses to deliver dystrophin sequencing are starting to show some promise. So watch this space. Hopefully there'll be further progression on that front in the future. But as we said, the symptoms of MD can often be relieved through exercise, physical therapy and occupational therapy, which is, I guess, the very small silver lining in this condition. So just thinking about the exercise response to begin with. So if you think about it, we've got a disease of the skeletal muscle system, of the skeletal muscular system. So if we're trying to exercise people, which we know is going to be using the muscles, it's kind of this double-edged sword, if you like. So there's a lot of anxiety about the role of exercise in disease progression. Can it actually cause more harm than good? Is it going to be appropriate? Is it going to cause harm? Is it going to provoke symptoms? What's going on? So, and also due to cardiac function as well. So not just the specific skeletal muscle, but also the muscle of the heart as well. So you almost get individuals with MD being trapped between the need to and desire to try and improve and maintain the current health, and also the risk, and the weighing that up against the risk that muscular activity might provoke delayed onset of muscle soreness, which is obviously going to be a huge issue for them. It's certainly normal in healthy individuals for muscle remodeling to occur post-exercise, but in individuals that don't have the ability to rebuild muscle, it's, again, question whether this is going to further accelerate that issue. So do we really want to cause muscle damage in people that can't build new muscle? So due to these reasons, and obviously people being very cautious about this, and the kind of the nature of the disease itself being in young people, obviously causing a lot of difficulty for parents and family members and all the rest, a lot of research today in terms of the exercise has been undertaken in rodent studies. But what they have found is voluntary exercise does have beneficial effects on muscle mass and walking distance without signs of exercise-induced muscle damage. Now, obviously that has a lot to do with the exercise stimulus, which we'll talk to shortly. There has been some research in adults with Becker's muscular dystrophy, and it was shown to be safe to participate in aerobic training at 65% of VO2 peak. So we're not talking about high intensity training here, but at that moderate intensity, it seems to be safe. Low intensity cycle ergometry also appears to be safe in children with Duchenne's MD. So overall, the key message is a little bit of exercise is going to be beneficial and safe, but we really need to be careful of not overdoing it and not obviously going to the other side of causing too much muscle damage and soreness. So on the whole, there's really limited research in this area, so it's really difficult to determine specific parameters for exercise. There are no ACSM guidelines specific for MD at present. Now, obviously, there's chapters and there's information around it, but there's not enough of an evidence base to go, this is what works, this is what we recommend. So it's kind of limited guidelines at this point. But as we say, the data available does suggest that light to moderate activities and intensities are going to be appropriate in terms of also considering how the individual tolerates them, but we need to be terminating them well in advance of fatigue. Okay, so we can't be going, we've really got to pull back how you would prescribe exercise for MD versus a lot of other conditions where we might be able to tap into those higher intensities. So one study here is looking at the resistance training benefits. So as we said, the research in this area is extremely limited, but resistance training in patients with limb-girdle and Becker muscular dystrophies. Now, we haven't spoke to limb-girdle today. Again, it's just another type which you can read up on if you're interested. But obviously, we are interested today with the Becker muscular dystrophies. So what happened in this study was they looked at the effect of low intensity training and high intensity training in muscles of the upper and lower extremities. So patients were tested for maximal strength and endurance before and after the training program. So low intensity training over 6 months resulted in increased bicep strength and endurance. High intensity training increased endurance and strength in wrist flexion and extension and in elbow flexion. One patient did discontinue the high intensity training due to muscle soreness and mildly increased plasma CK levels without strength deterioration. So what they concluded was both low intensity and high intensity training did increase muscle strength and endurance in some of the muscles tested and was well tolerated by most of the patients. So findings suggesting that supervised resistance training may be considered in the management of patients with both limb-girdle and Becker's MD. So obviously higher intensity training here was tested within that research and that medical environment, which isn't something, as we said, it kind of goes against official guidelines at present for people in practice. And there obviously were signs in one patient that maybe was inappropriate, but interesting to see. So you can look at the strength tests on the side and you can see the average percentage improvements for the various body areas in terms of strength. And it's pretty much 40, 50 plus for all of them. And then looking at endurance tests on the bottom, again, looking at pre to post. So you can just see the difference between the white and the dark bars there in terms of what the difference was pre and post intervention. So some good positive results there, but obviously not easy research to undertake. There's a lot of restrictions and things to be cautious of when you're dealing with these kind of conditions. So what we've got here is 11 patients with BMD and 7 matched healthy subjects cycled 50 30-minute sessions at 65% of the maximal oxygen uptake over 12 weeks. 6 patients actually continued cycling for 1 year. So they looked at VO2 max, muscle biopsies, echocardiography, plasma creatine kinase, lower extremity muscle strength and self-reported questionnaires before, after 12 weeks, and then after 1 year of training for those that continued. What they found was endurance training for 12 weeks improved VO2 max by 47% on average, and maximal workload by 80% in patients. So that was significantly higher than what was observed in healthy subjects, and that's usually pretty much expected when you're starting from a much lower base. You've got a lot more potential to see improvement. CK levels did not increase with training, so it's showing that there wasn't a heap or any kind of muscle damage or significant muscle damage that was present. What else have we got? Strengthening muscles involved in the cycle exercise. So your knee extensors, dorsi, plantar flexors increase significantly by 13 to 40%. And cardiac pump function. So looking at the cardiac changes, there wasn't actually any significant changes observed there, but obviously a whole host of improvements. So again, kind of highlighting that there is potential for exercise training in these patients when applied appropriately, safely, and the few patients that continued for the year showed that the improvements and the safety markers were actually maintained at that year point as well, which is really promising. So exercise recommendations, we spoke to some of these, and like I say, there's not a heap of evidence and literature that we can sort of go off, but on the whole, in terms of resistance training, obviously we can appreciate that stronger muscles are going to aid movement, posture, comfort and independence in these individuals. So where you can, you want to be trying to perform strength training or resistance training around 3 times per week. Now obviously you're going to have to get pretty creative with the various modalities of applying that resistance. So body weight could be sufficient, resistance bands, it's probably going to have to get out of your typical ways of performing, resistance and putting people on machines and throwing free weights at people. So as we noted, low intensity is going to be the way to go, but actually getting that resistance stimulus in some form is still important. Aerobic training, so can be difficult in people with sort of severe movement restrictions. Nevertheless, where possible, it should be undertaken. So even arm ergometers can be used for people that are wheelchair bound. You can also look to use low load resistance exercises, so more like a circuit training kind of stimulus, and that can actually help induce cardiovascular adaptations, as we know. So if kind of your traditional aerobic training is impossible, try and get creative with some really low intensity resistance and just higher volume in terms of trying to get that kind of cardiovascular response as well. But it is really important for trying to reduce body fat accumulation, and we know that's going to help reduce those cardiovascular risk factors overall. Finally, flexibility. So where possible, we obviously want to try and provide some kind of mobility and stretching stimulus. So we're going to try and improve joint movement, prevent those contractures from occurring and becoming too much of an issue, further inhibiting movement. And obviously, regular stretching, flexibility, mobility can really help reduce that muscle stiffness as well. Excuse a random emoji in the middle of the slide. A few special considerations. Now, obviously, there's a whole host of considerations for these individuals, but we'll just talk to the main ones here. So safety is absolutely key. So we really need to be careful about where people are at, what they are and are not capable of, minimising the risk of injury. If there is pain, then don't keep hammering through it, and pain is not a good thing in this instance. So I would argue pain is never a good thing, but you often hear the saying no pain, no gain, but it's certainly not appropriate in MD individuals. So therefore you need to stop what you're doing, modify what you're doing, and try a different approach. So as we noted, avoid exercise to the point of fatigue. Definitely avoid eccentric exercise, which we know is going to provide it's going to cause more DOMS, more muscle soreness. So we certainly don't want to be using any specific eccentric kind of exercises or approaches. And obviously consider, in 90% of the patients with Becker's and Duchenne's MD, we're going to see cardiomyopathy in about 90% of those individuals, and that's going to limit your exercise capacity. So we've got a reduced ability of the heart to pump blood, and could potentially lead to heart failure, and we know there's going to be a higher oxygen cost of activity. So just bear that in mind as well. So some of this stuff could be extremely low level, and it could look like it's not doing a whole lot from the outside, but as we noted in the studies, there's certainly a place for exercise for these individuals, and if we can make a little bit of difference, it can actually go a long way in their life and how they're coping with their condition. Finally, what we need to also consider are individuals' maturation, severity, the rate of progression, and the location of muscle weakness. Due to the nature of the condition as well, and the age group, this is an important but an obvious point. Make it fun, make it engaging, really try and create some kind of positivity in these individuals' lives, and create a positive attitude towards exercise, which is where that education piece comes in. So even at the most extreme cases of you might be working with somebody who has a projected, average lifespan of 26 years, what you know, and it's so difficult. I appreciate that. I'm not saying it's an easy thing by any means, but you really need to keep it fun and engaging, because if it's monotonous, if it's rudimentary, if it's dull, if it's delivered in, you know, a really rigid, boring way, then it's totally inappropriate. So keep that in mind as well. What are some ongoing challenges when you're working with these individuals? So this is just a wrap up. So we know it's a progressive condition, and we know that things are going to worsen and change, and the characteristics are going to heighten. So you need to keep that in mind. What you're doing at one time point with an individual could be very different to what you're able to do in months, years' time, okay? Continuous change in equipment, type of activity might be required. As we noted, you need to carefully monitor continually for signs of muscle breakdown or cardiac events. And of course, you need to maintain close communication with treating specialists. So it is a difficult one, guys, and I know like we've just skimmed over that, and we've only looked at 2 types of MD, and there's a heap more as you're aware, but I really recommend you get into the ACSM readings, get what you can on both conditions we spoke to today. And I'm definitely a visual learner, so you've just listened to me talk about this for over an hour or so. Get onto YouTube, have a look at some videos, listen to some patient stories, actually look at how it is impacting people, etc., etc., and just try and let it soak in and appreciate these conditions a little bit more.